episode of The Everyday Leader. I am here with another amazing guest, Dr. Moses Isiagi from South Africa. He is an expert in global surgery, in geospatial studies, and in public health. So, without further ado, welcome to The Everyday Leader, Dr. Moses.
Thank you. Thank you so much. I'm glad to be here, and thank you for reaching out to me. Yeah, so I guess I'm happy to be in this place.
Yes, my fellow global surgery comrade. It's always exciting to have, people here from, University of Cape Town, especially those that I met through the global surgery, executive leadership and global surgery program there. So yeah, we're talking today when our Professor Queen Salome has actually departed from University of Cape Town. So she found greener pastures. We're so happy for her. But I think now you have to shoulder the burden of keeping the alumni together. It's really on you this time around.
I would say we are a good working team here. So we are 10. We are 10 employees in the division, and the university supports us. Grateful for the faculty, and also grateful for our head of department, Professor Lydia Kencross, and the dean. So we are pretty in good hands, and Professor Lamy will always be part of us. So we remain in touch. Just grateful for what she did from a South African point of view and globally. Yeah. So I think we'll pretty be fine in the division.
Okay. Yeah. So glad to hear that. That gives me a lot of comfort. Okay. So it's so good to have you. We're just gonna dive into it. So, for people who don't know you, your work sits in the intersection of global surgery, geospatial science, and public health. So, what personal experiences, and was there a specific turning point that led you into this amazing career that you are in right now?
Okay, cool. I think thank you for the question. I always say I'll begin the answer in the same way. It goes back to my late mother, Mrs. Lois Agalo Ishagi. So on the 3rd of April 2010, to be specific, because dates and numbers keep in my mind. So that's how my mind works. So she was hit by a car on her way home from church. So she was a church deacon, and there was a wedding the next day. So she was hit by a car, and this is Kampala. She was left for dead in the middle of the road. So a church member carried on the back for he said it was about 10 minutes. So I received this random call. Then there was no GPS system in the place, no surveillance cameras, not what we have today in Uganda and the rest of the world. And for me, that's where geospatial science and global surgery actually begin for me, because in the absence so the system could not actually reach my mother then, and geospatial science works in tangent. It's a place where actually we're able to locate people. So 2 months later, after she was hit by a car, she began going blind. A tumor had developed on her optic nerve. So I took her to the biggest referral hospital in Uganda. That was Mulago, and the printout came with an interesting narrative. So my mom was 48 then, but the printout said she was 68. So I asked for a retest, but was refused because they said that there were so many people. But I insisted. I was called stubborn. I was called the land son, who thought he knew better. And that's where my journey began. So for 2 years, I crossed the streets of Kampala because we didn't have a car and the rest, and we had to go to a hematologist. Remember, in Uganda now we have about 10 to 15 hematologists for a population of 48 million. That speaks to the numbers. So we could only see him on the night. So going by taxis, the place was uneven for the time. So I had to tell my mom, now we are crossing a road. This is a ditch. This is how far you go, and the rest. And it was pretty hard for me. So we had to use about 3 taxis. Then later on, they managed to diagnose her. But I should say that on the 5th of April 2012, after she had brain surgery, she became brain dead. Um, and I remember when before she became pregnant, because I watched what was happening with the interns. I think they tried to feed her. She pushed her hand, and I think for me, then I told her that I would not accept the same things happen. So that speaks more to my geospatial journey, because the single promise is the spine of everything I do now, whether it's in pulmonary rehabilitation in the low resource communities. I think for me, in my mind, I do not want the patients we have now not to cross the roads that I did with my mom, having to go in the taxis and this. And for me, the citizen science bit of what I do is because the intern then refused to listen to me as a son. She insisted that the results were what my mother had. And I was like, no, I know my mother. And sometimes when we're interfacing with the patients, we don't go into the backstory because we think we are specialists. And for me, the citizen science speaks to a co-created, co-designed intervention protocol. So I trained as a sports scientist then in Uganda, and that still speaks to my geospatial bit because my master's was on pulmonary rehabilitation, and also looking at the objectivity of and subjectivity of your the built environment. So it's a mix of both, but I think my profession is much more linked to the death of my mother, a lack of access, and also a community engagement bit because I think from then I learned how to interface with the communities first as a co-created and co-designed aspect to it. So I guess that's the bulk of the story. But I would like to say that I do not study these problems now. I survived them, right? So I survived them. That's why I'm able to speak to an experience. And for me, the geospatial bit of it began where my mom could not be located. She was left for dead. So she was knocked down and left for dead. And I think the promise also that I said, I do not want the same thing to happen to someone that is not able to. And I think that speaks to my supervision and what I do now. So in short, mine is much more turning. I like to say um, scars into stars. So it's a mix of both. Yeah. So that would be in essence. So my life experience speaks to what I do now, whether I'm supervising, whether I'm interfacing with patients in a ward round, and the bulk of my work literally speaks to that. Yeah. And we know global surgery is about giving comprehensive care, equitable care to our populations. So in short, that is my personal experience speaks to what I do. Yeah.
Oh, wow, that's an amazing story. I'm sorry that, you have to go through all that and, your family had to suffer through those things. But it is really the it's kind of the story we keep hearing again and again and again and again. And you would think, okay, this is something that happened 20 years back or 15 years back. No, unfortunately, it's the story we still hear today. So it kind of begs a lot of questions there. And I think I hope we get to tackle a few of them as we go along in this conversation. So you mentioned that really the point of what global surgery research highlights is gaps in access and gaps in quality of surgical services. So from your perspective, what are the most urgent barriers that most African countries, whether it's Uganda or South Africa or any of the other African countries that you've been able to travel to, what must we address to close these gaps? And not just a one-time solution, but something that can be sustainable.
But I thank you so much for the question. I think in my research and the work and the stuff that we do in global surgery, I would like to say that there are 5 interconnected barriers that we have in global surgery. So we have a workforce issue. We have a geography issue. There's a financing issue. Right there, there's data, and also there's trust, and none can be solved alone. And I would like to anchor my work to a statistic from the Lancet Commission of Global Surgery, which we focus on in the division. The research strategy that we have speaks to what the findings of the Lancet Commission of Global Surgery in 2015, which says roughly 95% of the people in LMICs do not have access to safe, affordable surgical care. And the post-operative mortality in Africa is twice the global average, right? So more people die after surgery in Africa than from HIV, TB, malaria combined. So it's not really a niche conversation. I think I would like to say that surgery is a silent epidemic of African public health, if I'm putting it like that. But just speaking to the 5 barriers, the first urgent one I believe is workforce, not just for surgeons, because we need to capacitate the full surgical team, right? So from your nurses to anesthetists, the people that work post. So you have a biokineticists or clinical exercise physiologists that I am. So you have your perioperative physicians, the community health workers, and ASOS data from across Africa. So your Africa Surgical Outcomes study that Prof. Bika did with Prof. Salome and a team of great individuals clearly shows that complications are most post-operative, not in theater. So a country can have the best surgeon and still lose patients on the ward because the system around the surgeon is thin. And I think that's what we have in our African settings and also in other LMIC settings. The second barrier that I spoke to, because I said 5, would be geography, and the recent work that we did with my colleagues here in the division, and also other colleagues in Faculty of Health Sciences, shows that proximity to a hospital does not equal access, which is interesting because sometimes you'd think that proximity to a hospital actually means access, but we know that in our settings that proximity to a hospital does not actually equal access. So in peri-urban Cape Town, where I am, so in the study that we did, that people live within a site of a facility and still cannot reach it because it's costly, number 1. 2, there's a safety issue. 3, there's a language issue to it, and also how the referral pathway is designed brings much more barriers to the people. So proximity to a hospital actually does not equate access, and this is what we call the second delay from a global surgery point of view, because you have a delay in seeking care, a delay in reaching care, and a delay in accessing care, and they're adding on the 4th now, a delay in actually having appropriate care thereafter. So the first I hinted on was a workforce. The second one would be geography. The third barrier is financing, and we know that in sub-Saharan Africa, health spending is both inadequate and inefficient for most of our African governments, and just roughly how it's set up. So surgery in most national health insurance schemes is either excluded or capped or reimbursed at rates and incentives where it leads to under delivery, and until we're able to actually cost what this is, it becomes then a big barrier. So there's that financial aspect that we still have to grapple with from a global surgery point of view. So one, I said, was a workforce. Second was geographic. Third, a financial bit. And the 4th barrier, and this is where my geo-spatial work deals with, and also the foundations of why I'm in global surgery. Most African countries cannot answer the basic Lancet Commission indicators. How many surgeries per 100,000? What is the surgical workforce density? What is the geographic accessibility to our patient populations? And I think, so from a geospatial point of view, from an African point of view, where you are born, so it's interesting. Where you are born determines if you'll actually live. In some settings, where you are born determines if you'll have adequate access, and it speaks to a geography and a geospatial aspect to it. So we have, and some of who are actually not able to get some of our patients. And you'll find that even when you're doing your geospatial analysis, that you have overlapping addresses, so you're actually not even able to provide care to someone that needs it because it's an overlapping address to it. And from a geospatial point of view, the bulk of my work speaks to it. The fifth barrier is trust, right? And again, I said trust because my initial touch base with the system was a health worker that refused to hear me out. I said, my mother is 48. Why are you giving her results for a 68-year-old? And with that, you're able to lose trust with the systems because over and above, I had to keep on moving. I actually stopped working that time, had to move with a blind mother for 1 year. Then she ended up dying in the process. And this is where we actually lose the bulk of our the patient community because there's a lack of trust. We don't trust the system because if you go to the system and the system refuses to hear you out, then um, mostly it won't be there. That's why I focus on the citizen science bit because it's a co-created, co-designed, and I'm empowering the community and saying, I hear you, I see you, I am part of the community, I am the community with you. So I think to break this down, I would say, um, in principle, that more deaths follow surgery in Africa than from HIV, TB, and malaria combined. But and also, I would say in bold strokes that proximity is not access. A hospital, you can see a hospital, but you may not be able to actually reach it because it's interestingly most of our public hospitals in Africa on a hill. I don't know if it fits from a colonial aspect to it, but you can see the hospital, but you'll never be able to reach it. And we will not budget for what we cannot measure from an African point of view. And we will not be able to measure what we do not value from a global surgery point of view. And the communities actually that we interface with do not refuse care. They just refuse the care that does not respect them. And for me, it was a point of I am not being respected as a son, and I still build that in my work. And I think I'd still emphasize that the communities do not refuse care, but they refuse the care that does not respect them. So if you do not respect a community member, listen to them, they'll probably refuse the care. Not that it is not there, but it's because there's a lack of trust in the system. So broadly, that's how I put it from the five barriers that I see. So it's workforce, geography, there's a financing bit of it, and there's a lack of trust that we that is in with our communities.
Yeah, wow. I love how you kept mentioning that it should be co-designed, right? It's you're right. For a country, most countries in Africa and other LMICs, where you have a lot of health seeking behavior and even services are heavily influenced with cultural norms. Co-designing them is really the key to build that trust that you just mentioned. Just because you didn't feel valued, even if you had legitimate questions about your mother, you, like you said, it affected your trust and reliance on the services that you were provided, and that's obviously going to affect adherence, and it has a rippling effect, right? So co-design, I love that. So you mentioned all these five barriers, right? Is there a silver bullet that would address all these barriers, or do we tackle them one by one? And if we tackle them one by one, which one is the priority?
I I think breaking them down, I would like to say it's a community bit of it because my definition of a community is it has two lenses to it. One, the specialist that you are that is living in a community, and the patient community. So unless we come to that aspect of understanding that, and I think for me the issue I have with some of my colleagues is they say let's go to the community. like what are you talking about? They are actually you are bits bits of a community, and it has to be co-design and co-create. And now I'll make mention of my PhD work. So because I was doing a citizen science bit, I went to them and was just asking the basic questions. What do you know about lung health? How would you, in your setting, how would you treat an issue of COPD? Like, no, we know what that is. This is how we do stuff, but the system never hears us out. And so with them, I was actually able to co-design and co-create a community intervention. And when you co-design and co-create with the community, then that's one of the aspects where they'll be able to trust you. So when I go to the community, they're also able to say, oh, thank you so much for coming back to us. We appreciate what you're doing, Dr. Moses. So whether it's with the and I'll just let you know. So because I am about 15 or 20 kilometers away from the university, even the taxi drivers are my community. Now they'll say, oh, Dr. Moses, today don't pay for anything, because they realize that, oh no, I am actually part of the community. And I think most of us don't have that aspect, and they're able to tell you, okay, my uh, my wife, my grandfather has diabetes. What do I do in the system? And I think once we're able to see ourselves as partners in intervention, then the hierarchy bit goes. So all these other things then uh, are you're able to work through them. And I think the answer is in co-designing and co-creating, and just being able to redefine what community actually is.
Yeah, great points. I love how you highlighted both sides. And also, just to add on that, you see a lot of fracture even within the healthcare community, right? There's a lot of disconnect between different departments. Instead of working together, we kind of work against each other sometimes, which is I don't even know how that happened, but it is the reality. And when you look at administration versus healthcare workers and actually giving the clinical services, there's a huge disconnect there. So, like you said, that parts and beats of community, that sense of belonging to the same goal and vision is very important to rally people towards a greater change. So I love that, and I completely agree with that. So we've been highlighting the need for and the importance of geospatial determinants of health, and um, how can our health systems practically use this sort of research and data to improve equity, and whether it's in surgical or public health services. What's the practical bit of it?
Okay. So the practical bit of it also just speaking to what geospatial determinants of health are and how we can actually turn equity into it. The basic idea is simple. Where you are born, where you live, and where you work, and how you move shapes your access to healthcare, just like biology does, right? So where you're born and all this stuff. So in a way, where you are born, or where you live. So the social determinants of health tell us what shapes health, right? The geospatial determinants of health tell us where those shapes sit on the ground, right? But I'll break it down. So I think I would put it like this. Um, from a practical point of view, in Africa, and what we need to do is first we need to map what we have, right? Most African countries do not have an up-to-date geo-coded inventory of their own surgical facilities, right? And that speaks a lot, because if you're not able to map where the facilities are and where the population is, then it's difficult for you to actually be able to provide an intervention. And second, from a geospatial point of view, so what we did with our study, we also for my master, we used accelerometry and the rest, being able to map how far the distance is. Because from a secondary point of view, a grandmother would probably tell you she's 5 minutes away from a hospital. Or I would say a son that is active is able to say, I'm 5 minutes away from a hospital. A grandmother will tell you, I am an hour away from the same hospital. Same, different perception. So, from a geospatial point of view, when you actually map these distances, you're able to tell and you're able to factor in all the things. Why does a grandmother say she's 1 hour away from the same hospital that a son says it's 5 minutes away? So you're able to add in all the things, but we do not have the objective layers to it. So we still work with our patient perceptions, because when you ask a grandmother, how far is your home from you? She'll tell you it was an hour, but then you haven't factored in shared issues on the way. All this stuff was happening. So from a practical point of view, we actually need to geocode these places so we're able to have up to date, objective interventions that we have. And again, I would put it this way, or I would like to angle it this way. For a woman in labor to reach a cesarean section on Sunday in a hospital, how much time does that take, right? So from a geospatial point of view, if you're doing Uber, it will probably tell you 5 minutes. But then remember, in some of our informal settings, it's a whole long distance and all these other things. And I think from a geospatial point of view, if we're actually able to map these actual places, we're able to reach a patient at any one time. And my mother was not located in the system. If it wasn't because of my friend, maybe should have ended up in some mortuary, and I would never have known, because we didn't have all these other stuff located in. And I think the third would be we from a geospatial point of view, what that does is you're able to loop in the community with the maps, because at the end of it all, the communities that we have should actually also be able to read these coordinates. So if we're co-designing and co-creating with them, you're able to tell them, okay, now on this map, this is where the hospital is, this is your safety test, this is your fastest route. And then, of course, from an informal point of view, they already know. But if you add in a geospatial aspect, you're actually able to map it per se. So I think just to summarize this, I would say that the social determinants tell us what shapes health. Your geospatial determinants tell us where they are actually on the ground and what we need to sort out. You'll find out that for most urban centers, within a radius of 5 kilometers from the airport is a whole different life expectancy, and still that speaks to your geospatial coordinates. And the second summary I would say that is you cannot redistribute what you haven't located, because most times we say we want to give access to the communities, but if you haven't located it, how are you able to redistribute it? And also proximity is geometry and access is geography. And if you add in money, you're able to bring in with a safety and dignity aspect to it. So I think broadly, your geospatial determinants of health turns equity from a slogan into a budget line, right? Because you're able to map the place, add in the geography, add in the time, bring in an aspect of money, then the safety bit of it comes, then over and above, the dignity bit of it comes, because you're actually able to locate the communities. I don't know if I've been rambling, but that's how I would place it. And I don't even know if I've given a practical bit with it, because we still engage with our other colleagues from the built environment and from public health to be able to actually map this out, because this is multidisciplinary. You cannot only do it from a global surgery bit. It needs your urban planners, it needs the ministers and all these other people to be in it. Yeah. So that's how I would put it.
Yeah, a lot of moving parts there. I'm just curious to know, from your studies so far, have you found anything on ground that we can use for our advantage, the way maybe our community is constructed so far? Um, because it's yes, when you're trying to solve a problem, you obviously focus on the problem, but
Mm.
are there is there anything that is already existing on ground that we can use for our advantage on how our communities has been constructed so far. um, when you do co-design, is there
Yeah.
anything that already exists that you can integrate?
Yeah, definitely, because you already have your informal networks also. So from a South African point of view, we have what is called, other people call them community health workers or your community liaison officer. So when you're co-designing and co-creating, I like to tell my students that there's one person that is actually able to give you a buy-in with everyone. So your community liaison officer knows who is sick in the community, what patient needs this, and also knows what taxi driver should be able to get to take it to the place. So while we are bringing an objective layer, they already have your informal settings, and if you merge the two, then you're actually able to redefine instead of going to look randomly for the patients. Also, you're able to actually use your a community liaison officer. So we already have this that have been set informally. So what you're just adding on is an objective layer where someone is actually able to reach on time. So you're able to, because if, even for anything, in order for you to reach the community of the patients, if you go to them, they're able to tell you this. And I like how it's done in South Africa. They're actually even able to go to Parliament and do all these other things. So it saves you so much because they are part of the system. They are equal. The community listens to them before they listen to you. So when the community sees you with them, they're like, okay, now we trust this person because they have. So we have this already now in our settings, and I think it shouldn't be that we should go and redesign because we're able to use what we already have. What we're just adding on is now an objective layer. If you need to transport or if you need to give medication to a community, there's one central place that you're able to go to, and there's also a referral pathway that you don't need to do all this. It's just one person that is able to give you a buy in. So we already have these networks, and we could utilize them, especially with our low resource setting bit.
Yeah. Yeah, I think that's very important to just identify what already exists. That's at least half the work done right there,
Mm.
right? So that's so good. Um, so for especially underserved areas,
Yeah.
people who live in the city, they have a better shot at access, even awareness, and even better quality of care, right? Where the underserved areas just get the short end of the stick
Mm.
all around. So in those areas, what which things would be priority for you to address? Where do you start?
I think the I would like to say it this way: the issue that we've had as clinicians is we want to go with a top-down approach. Like you probably say, this community has all these other things. Then we want to take an intervention, but it's just going there and just actively listening to them and just asking how are we able to do this. And I think I would use uh, my PhD work. So Wendy wanted to do a COPD intervention, which is a chronic obstructive pulmonary disease. So I went in, wanted to do the intervention as a clinical exercise physiologist. I'm already saying probably this is what I would do. What does this is how it's set up with the community. This is what I would do. So I asked them, uh, what do you think would be the best? Interestingly, this community tells me that we have a smoking problem. We know that we have a smoking problem. So the first thing that you do, instead of giving us an intervention, we want you to tell the government to ban smoking. All right. So, and this is coming from them, not coming from me. Then they said, okay, in your random whatever you're doing, this is what would consider the first priority instead. Then they said we have a safety problem and would like that if the thing is put in a church space, then we'll be able to do this. If I'd come with a lens of saying, well, I'm a clinician and all these other things, then I'd have said this is the priority. But just having a conversation first enables you determine what would be the biggest thing. Because for some cases, you'd think that, okay, now I need to solve this and everything will be fine. But they're able to tell you no. And also I would say from my PhD work, the interesting thing was, so in the community they had a third. It's almost like they had, so they would give them medication for your COPD, but they had a third party that sold them the medication, telling them if you take this medication and you smoke, your lungs will be fine. So the issue was not that they were not having a DRS, but there was a third party that was selling the medication to them and promising them that if you take this medication and smoke, your lungs will be fine. So what would be your priority as a clinician, right? It is having a conversation and telling them, actually, this is what your lungs look like. If you take this, you're actually going to become a. You'd have said, let's ban smoking and all these other things, but there's a third party that the community trusts that you need to engage with and the rest. So, and I still emphasize that we have to listen to the community and have trust before we put out anything. Again, I'm emphasizing co-design, co-created, and community, because mine is a lived experience of what it is.
Yeah. Yeah, I couldn't agree more. That's such an interesting example. There
Yeah,
because there are
because I
all
think
there are multiple players when it comes to healthcare. Like what we think, especially as clinicians, and I'm no different. I'm no exception, right? We just think inside the four walls of a hospital, and we don't see all these things. But you're right. If as a clinician, you're trying to treat a patient, but to treat the patient goes out there and somebody's telling them the exact opposite of what is true. So, and it really you highlighted that, there are multiple players in this, right? You have finance, people in finances, policymakers needs to be involved, urban design needs to be involved in this sort of things. It's not just a healthcare issue. It's like you said, it's a community issue. But also this goes to highlight that the legal system also needs to be hyper vigilant and active, because this is violence. If you think about it, you are misleading, misinforming people to something that might actually not only risk their health but lead to death. So it's just, yeah, there's so many things to think about. Yeah, I love it. Thank you for that example. um so I know you have advocated for integrating geospatial analysis, statistics, and those sort of technology into the public health curricula. Um, so, which is very important. I am, as a teacher, also an advocate for integrating whatever knowledge, whatever change you want to make, you introduce it at the level of universities, like undergraduate programs, right? So that someone would have that lens when they actually go and start practicing and be part of the system, versus having someone who've worked in one environment for 20 years. It's hard to give them a training for 1 month and expect them to bring about change, right? So I really admire that approach and advocacy that you have. So what skills, okay, do you believe that the next generation of the African health professionals um, must master to lead in a highly evolving, fast-paced environment, but still have an impact at the same time?
Okay. I would put it broadly because I supervise your electives that would be undergrad, international, masters, and PhDs. But I would say there are five literacies that you need. One of them is data. Two, you need to have geospatial knowledge. Three, you need to be able to communicate. There's a community and ethical leadership bit of it, which I keep on emphasizing. And I would say from a data literacy point of view, the students must be comfortable with the R, Python, and RedCap, because if you don't have basic stats, you're not able to interpret. And for the most, previously would leave it with the stats guys, and it's like, okay, now I'm writing this, go figure out, interpret all these other things to me. But if you're not able to do this, then it becomes very hard for you to have accurate conclusions. You're not able to actually get an intervention if you have passed this on. And I like telling my students that you have to be able to interpret your data, and going to the future, you need to be able to analyze and say, okay, now I'm picking this up from my data. I should be able to analyze it. So at basic level, just have your you should be able to do red cap. Should be able to just analyze your own data. But I think it's a great skill that is needed for the future generation. So one is a data literacy bit, and again, it speaks to a geospatial literacy. So you need to be familiar with things like your Google Earth engine, your GPS. We do that with our movements now, your Uber, taxis, and the rest. But that's just more in your public places. But we need to be able to interpret data, because if you're to break it down, you should just be able to say, okay, now if this is geocoded here and there, I know that you're advocating for it. You could get someone in the system to be able to help you, but at basic level, just having just sorry, the flu, just having a basic knowledge of how to do something goes a long way in actually how you frame your question. So one, data literacy, again, geospatial literacy. Maybe I am biased because that's where I deal the most. But third would be your communication literacy, the ability to translate a finding into a policy brief in one page. I think that's what we need as clinicians, because we write so much, we do all these other things, but just being able to translate this to a community goes a long way. And I have co-authored policy briefs and this, and us just being able to give this knowledge to a community would be better. Again, I would like to use examples, because if we're not able to translate our work, it becomes that. Giving an example to where I'm from, in some parts of my country, there's no direct equivalent to surgery, right? So if I'm to go and tell my grandmother that she needs surgery, you would liken it to how you slaughter chicken. Like, grandma, you're going to be slaughtered, because our African languages abroad. So if you to tell her that you're going to go under anesthesia, you have to tell her that, grandma, you're going to die on the table and resurrect. Literally, because there is no direct translation to it. And we should be able to, to communicate all this. Then you imagine I'm telling my grandma that you're going to be slaughtered, number one. Two, you're going to die on the table and resurrect, right? So there is no forum for us to be able to translate all these big things that we say for our community. And who's going to trust you if they say, one, you're going to be slaughtered, two, you're going to die and resurrect? We should be able to, from away, be able to translate our language, what we have, to the community person that is that is not able to understand all these big bombastic words that we have. What is anesthesia to my grandmother? How am I able to translate that? And I think fourth, again, it speaks to community literacy, and it's the humility to know that a citizen in Manenberg, which is near me, or in Mukono, in where my family is, knows the things about their own health that no textbook will ever teach them, right? So being able to have this literacy with the community, because imagine the example I use: the community trusts a third party who is lying to them, right? So them just being able to have a literacy that if you smoke and also take this, it's more. So the bit of our communication literacy should also be able to translate into our communities. And I think the fifth bit of it would be ethical leadership, and it includes integrity, whether it's in our authorship, whether it's in funding, whether it's in supervision, and it includes refusing extractive research models where African data files are taken to the global west, then brought back to us. There should be an ethical leadership aspect to it, and I don't even need to I don't even need to preach about this. So there has to be a pipeline where there has to be an integrity in how we're doing our things. So just breaking it down into the things I've said, the next generation one must own the analysis and not delegate it, right? So own your analysis, do not delegate it. Be able to understand the analysis. That's the first bit. And the second bit will be a beautifully written paper that no minister will ever read, changes nothing, absolutely nothing. You write the paper and your minister is not able to read and interpret it, will change nothing. It will probably just go that side. So write beautifully, but also your minister should be able to understand it, and then you'll have change. And just for the community would be, the community is not a study site, because most of our communities are a study site. The community is the co-author. How many of our papers do not have communities acknowledging them? The community has to be a co-author. And if we're to move further in this, they have to come in. And I think Africa does not actually need more employees. Africa needs leaders that are actually able to have an ethical bit to it. We have seen it with our leaders. I do not want to be a politician here, but Africa does not need more employees, but actually needs leaders that are integral and are able to understand community priorities for the future. So that's broadly how I would break it down.
Wow, those are great points. I think I want to go back to school. um, so yeah, and I want to, learn through this, go through this curriculum, because it really, you made it sound so simple, because you have thought about this, you have worked through those points, and you've seen their effect and their impact, so that's why you can synthesize them the way you've synthesized them. But it's very hard for a lot of people to wrap their minds around it. I know, for example, when you say do your own analysis, a lot of surgeons are falling off the wagon just right there. They're like, nope. Yeah, because unfortunately there are certain truths is that research are being done for advancement in academia, which is, there's nothing wrong with that, but not necessarily to have an effect on policy or to bring about community change in their community, right? Even though their family and them themselves belong to that community. So there's a lot of short-sightedness when it comes to that aspect of our academia. So yeah, those are great points. Leadership is the last thing you highlighted, which is very important. And for your work, especially your PhD work, it spanned across, if I'm not mistaken, over 20 countries, right? 23 countries or so. So what leadership lessons came out of that? Because you have to work with, healthcare workers, patients, and community members as well to conduct this research. So what leadership lessons came about from this experience for you?
And I think I'd like to say my PhD, the model was driven by absence, right? I would say absence. And the lessons that I got from it was humility and the courage to lead from behind. And interestingly, for LMICs that, so from a COPD point of view, about 65 million people die. No, so 65 million people are affected by COPD, about 3 million die, the bulk of them are in Africa. So when I went in, I think it started with my supervisor, I went to him, there were guidelines that were given, but they had been written far back, and I was like, how can we be in a place where we actually don't have your guidelines? So it began from a place of absence. So, and I think, I don't want to put it out there, we have what we call the gold standards, right? We like that word, gold standard. It speaks so many things. So when I wrote I wanted to find out from clinicians in Africa what are the gold standards to PR rehabilitation. Interestingly, when I did a systematic review, there was no data to it. So how then are you able to treat something where there's no data, and we have been given an apparent gold standard? So it was a place of let's move from this, move to that, and move to that. And I would like to say that my thesis had three components. First, it was a systematic review, just looking at the gap. Second, it was, like you said, I dealt with 23 countries that we have in Africa. So it was a cross-sectional study of healthcare providers. So across our uh, Pan-Africa Thoracic Society, South Africa Thoracic Society networks, just asking them what the gap is, if they knew what pulmonary rehab is and what they do. And also I wanted to interface with the no-do gap. And this is actually central to our work. The third component was one, literally that changed me because it was in a partnership with the guys in the community. So we used our voice to ask the community, what do you think about lung health? Get me a picture of what you think affects you, how we're able to actually do this. So again, it speaks to it being a systematic bit. The absence bit of it, there were no guidelines to it, to asking it from a continental level, then coming to the population that you actually need to interface with it. So interestingly, I think the bulk of it was a humility of the community telling you this is how we want an intervention to be co-designed, and that is where the leadership questions are. So the first leadership question lesson I learned was leading from behind, and most of us like to lead from the front. I liked telling Prof. Salome that there's a difference between a leader who serves and a servant who leads, right? Those are two different things. So and for me, my first lesson is, and the most powerful one, that is, you sometimes lead from behind, allow the people to discuss, because in between you're actually able to find what is a priority from a community, what is missing and what is the gap, and you're able to focus on that and you're able to get an intervention. So my job was to just sit, listen to them, and just be present, be honest, and tell them we're co-designing, we're co-creating this. What do you think? And I think my first lesson in leadership was, I'm gonna lead from behind. I won't show up and say, no, I'm here. This is what we're going to do, 20 minutes or so. Sometimes you'd plan for an hour, but you end up being there for 3 hours because so many other things come through. The second was data and dignity must travel together, right? So your data and dignity, because most of the times we just take the data, but there's no dignified approach to it. So you're working with clinicians who are overstretched, most are underpaid, and also for the survey time you have to be patient with the guys, because and we see it with our, I don't even want to speak to our the peer review, where they send you a peer review and they tell you, okay, we want it in the next 10 days and so, but it still speaks to production and the rest. You have to give a place, you have to look at the people that are providing data from a humane point of view. And I think that's where I learned to be patient, because it took time. You have to keep on probing and asking them to send through the data. And again, I say one was lead from behind, two, your data has to move with dignity, because we like working with timelines, of course. We say, okay, now, if I'm not there 3 minutes before a patient is going to die and the rest, but this taught me actually that you actually have to be patient over time. And I think the third lesson is the system will not invite you in. You have to build the table, right? Because we have a system. It will not invite you in. You have to build and say, I am going to go to the community. This is what I'm going to do. This is how I'm going to figure it out. And most of us wait for the system to be able to help us, but you have to actually go to the system and say, I am here. I know I am at the mountaintop, but I'm reaching out to you. So you have to go to the system instead of waiting for the system to bail you out. Most times we wait for our ministers to bail us out, but we're actually able to actually go into the system and be able to show, because if we're able to interface at a scientific level, the community should be able to interface with us. So I think three, lead from behind. The data has to move with the dignity, and the system will not invite you in. You have to build in, because I had to show them that geospatial analysis is needed in our surgical spaces. So I had to go into the system other than waiting for it to come out to me. So yeah, that's how I would say it. So I think, just to break this down, I would say that we're not just missing the service as clinicians, we are missing the diagnosis upstream, right? And I would say, so for my PhD, 85% of the clinicians knew what to do, but none of them had access to what we call our gold standard. So you know what to do, but there's no access to the treatment. So what do you do? Because it's a low resource setting, so you have to co-design and co-create. Because if you know what to do and there's a resource constraint to it, then what happens? And the third is, African leadership is often quiet leadership, right? For most of the people. So the courage to be silent so the community can speak, for me, was a big thing, because most times we're like, no, I am Dr. So and so, I've come here and the rest. But the courage just to be quiet and listen to them, I think for me, is what works. So literally move from a servant leader upwards. So build a table, no one is going to invite you in. And I think Prof. Salome did a great work. She built a table because no one was inviting her in, and we have global surgery in our spaces now. So yeah, that's how I break it.
Amazing. Love everything.
I feel
Um,
like,
huh?
yeah, I feel like I'm rambling, like I'm saying so many things, but yeah.
No, these are great points. Because first of all, it's very hard to synthesize life experiences in few words,
Mm,
right? Because
mm,
you think of something and you're like, oh, wait a minute, through that I also learned this. Also, because of
mm,
that, I learned this. So it's like
mm,
it kind of transforms you without you
mm,
even being aware of it. And then when you reflect, you see you see all the big things
mm,
that have affected you and how you lead, like you said. But I think the servant leadership is very underrated in our environment, um, probably because of poverty and how leaders have been, painted throughout the years. It's either those people with wealth within our community that become leaders, and instead of serving the community, they're kind of serving on top of the community and like giving out orders instead of keeping the interest and the greater good in mind. So really need to change that perspective that we have about leadership. And this to have anything impactful is really requires you to humble yourself, like you said. um, just remove any mask and facade that you
mm,
have where you think you've what you have achieved, and listen, um, because it's thinking that you know everything is the greatest communication breaker, right? So you have to go in with, I don't know anything. These people know what they need, what's more important for their community, more than I could ever imagine and understand. So I'm here to learn, right? So you mentioned really good points, and I think those are very important. Um, and you mentioned a word, from a place of absence, which is literally our entire life, especially those
mm,
of us who work in healthcare. Um, so for young people, they may be students, still in, hoping to join the healthcare system in the future,
mm.
or they may be early career professionals or mid-career professionals. What would you advise them to, if they want to lead an impactful research or shape policy or just be innovative in such an environment? What would
Mm.
be your advice?
I think I'd like to say it's cliche. I would say you, and I kept on growing up with, I didn't even give a background of not being my dad not being able to provide for me my entire life. So I would like to say is you have to hustle until when you don't have to introduce yourself, right? Um, but it still speaks broadly to where we come from. And I say that let the scars you have become your stars. And I want to speak to a 16-year-old somewhere in Mbale, in Uganda, here in Kailicha, Yaoundé, Cameroon, who's listening. Because I think one of the things I would say, in my from my primary 4 to my primary 7, I wore my mother's shoe, right? Because I had 7 sisters, and if you're buying, you have to buy in bulk. So I wore my mother's shoe and couldn't go out because I was embarrassed wearing a woman's shoe at my age, which happened to be my mother. I was the same shoe size with her. So I sat in class, hiding from the teacher. He used to uh, come to me in my secondary school. So at some point, so I'll tell you from my high school point of view, I used to be shamed for not being able to pay fees. So this man would come and say, okay, now we know there's a student that doesn't pay fees and all these other things. So what happened, because I was in a day school, so most of my in a day school, that meant that I would go to school at the end of the day to be able to pick the notes and be able to study on my own. So it's almost like I was a day behind in the way I did myself. So it speaks. That's why I said you have to hustle until when you don't have to introduce yourself. So I learned to be self-reliant, that I'm able to understand geospatial stuff. If you take me to a place, I'm able to understand. And I think I would like to give someone or out there that if you're given an opportunity, maximize and just utilize it. And I say opportunities have a deadline. So that's the first thing I would say. Aside from everything, opportunities have a deadline, and miracles have a schedule. So sometimes we say that we are uh, waiting on God, but the thing is, God is actually waiting on you for those that are people of faith. So you have to do the bare minimum, and opportunities literally have a deadline, and most times we don't see the opportunities we have. Second, the foundation still goes to before the building goes up, because most times we just want to be in the surfaces. Global surgery, from a UCD point of view, has been 7 years in the making. 7 years of being in the office for a long time, of uncertainty and the rest. And in between, this is where the learning experience is. Three, like I said, you have to hustle until when you don't need to introduce yourself. You have to keep on writing, keep on being in these spaces. And I think this is just general. It doesn't even speak to my work, because sometimes we wait for our ministers to help us, but just remember, no one is going to come out and help you. And I think find a supervisor who's more of a mentor, who understands where you are, who's able to build you along the path. And there's so many people that have done this to me. My master supervisor, Vicky Lambert, incredibly great. My supervisors for the PhD, Dr. Kofre, Professor Van Zyl, and all the people that have made me who I am, from a University of Cape Town point of view, the deans, and somehow you have to find these people, because it is a village, it is a community. Look at the other person beyond your work. There is a community aspect into it. And I think for me, I would still say let your scars become the stars, because my story is one of luck. And I would say I was born in a place of abject poverty, right? My dad was not able to provide because he lost his job when I was born. So that means I had to be in the top 10 right from my primary school to secondary and all this. But it still spoke to, even in absence, even in a place where I'm not able to get, what happened. So there is that bit that let the scars that you have literally lead you to the light. And I think this is just general that I would give to someone out there, that At some point, I had zeros because I have fumigated. I've done all these odd jobs that have enabled me to reach where I am, where I'm actually now able to interface with people and tell them, I was here before, I see you, I feel you, and all these other things. So, general, I think I'm just giving broad strokes. Opportunities have a deadline. Two, your foundation speaks. Three, get a community of people and make education fashionable. And I think I have literally come to these spaces because of an education. If it wasn't because of education, I don't think I would be sitting here, but I was able to maximize even with absence. So I think that's how I was. If you don't make an excuse for excellence, just do your bare minimum. Maybe this is a topic for another day that is outside your global strategy spaces, but I think at the end of it all, those things have kept me. The faith that I have, the excellence, and knowing that if I'm given an opportunity, I should give 100%. In the absence of your boss, you should be able to give bare, you should be able to give an excellent bit because eventually it will show in your work ethic. Yeah. So that's what I would tell someone who wants to be in our spaces out there, someone that is thinking that the world has ended. And I think broadly, I would say that I decided to trust my unknown future to a known God, and that speaks to my faith. So yeah,
I love
broadly.
that. Oh my God, that's such a good advice. I felt like you were speaking to me as well. So I'm like, thank you so much for that. So many powerful things you've mentioned. And yeah, I mean, I know the conversation has come to an end, but I will definitely be looking out for all the great work you're going to be doing in the next few years, how the work you do affects policy and brings about real change, and how it inspires young people down in the pipeline. So thank you so much, Moses. I really appreciate you dedicating your time for this conversation. And I believe a lot of people would walk away with valuable lessons once they listen to this interview. And I hope to have you back on soon.
I thank you so much. You decided to bring me to office on a Saturday, so I'm the only one in the corridors. But thank you for inviting me. And I'm glad that you thought me worthy to be in this spaces, and thank you for the great work. And